I am educated as an ICU nurse. That's my background. I did
ICU. What is that?
That's intensive care
Yeah.
nurse. So I did work 10 years in the local Copenhagen University Hospital as an ICU nurse, intensive care. And then I was picked up by a gas company that is a global gas company. I was picked up by them in 2008. And my job for that company was actually with the nitrous oxide molecule.
Okay.
Educating staff, educating midwives, educating doctors. Along that journey, I started visiting Swedish hospitals. And when we started to talk about the climate effect, they were like, Mr. Jensen, don't mention it. We have it covered. And this is back in 2008. And I started to dig into it and say, hey, why do you say you have it covered? And they said, we destroy it. And at that time, I was like, what are you talking about? You destroy it. And I remember that they took me to a basement and they showed me like an oversized fridge at that time. To me, it looked like an oversized fridge. But it was not an oversized fridge. That was actually a destruction device. We're back in 2008. And I work with an old technology. That's also what I kind of mentioned, is that along the sustainability road, there will be a lot of good ideas. A lot of good ideas. And I think basically, we're now in a situation with our climate where we should use all of them.
For sure.
But some of them are well tested. And this technology from Sweden, I think we could say that is well tested. It's an old technology. It's from 2008. It was installed in the first Swedish hospital in 2008. They installed the nitrous oxide. This is 14 delivery rooms. It's the biggest hospital that we actually have in Copenhagen or in Denmark, at least on women coming in giving birth. It's 7,000 babies per year. 14 delivery rooms. Now they start to pipe in the program. So you have like huge cylinders in a technical room. From that room, you have a pipe going in, and that pipe then runs into each and every one of these 14 rooms. There is a mixer. And then they titrate to the right level according to the women that kind of needs this. That's where we started. They have the program. Then they also knew that they're leaving behind a footprint. So after they installed the nitrous oxide program, they made sure that the pipe that they exhale back to was let into the same technical room where they had the cylinders. The pipe was let out to the climate because they needed, of course, to finance the central destruction system. It cost money, absolutely. So year one, that's where they installed the program. Year two is where they took the pipe running out to the climate and redirected that into our central destruction system. So patients inhale it themselves. They control, however much they need. Some places will use a mixer where you can titrate to different levels. When you're going to become a dad, I'm sure that you and your wife will experience that is what we use here in Denmark. You can set different levels. So your wife might need 50% nitrous oxide. She might need 25. Okay. Here in Denmark, midwives are extremely well educated. So they will know that 50% is the ideal dose. They might also think that at some point your wife perhaps doesn't need that much. Maybe she has a side effect. Maybe it's that's even euphoria and she lies there and laugh a little bit about it. They will then go down to 25%.
Okay.
This is good for the climate.
Yeah. So, the less gas, the less...
So they are extremely well educated. What now is a concern is, of course, what do they do with the exhale gas? What happens with that? And here in Denmark and in a lot of other countries, staff are extremely well educated and extremely competent about it. So they know that they need to capture the exhaled gas because of safety for themselves.
Yes.
That's the main driver for them, safety for themselves. Now we come in with our technology and say, okay, the gas that you now capture, where do you lead that to? Traditionally here in Denmark, our hospitals have led that to a ventilation system. And that would mean that this just goes unpassed, unfiltered out to our climate.
Yeah, into the atmosphere. And then we're back to this. It has a very high global warming potential, meaning that it's equivalent of emitting 273 or 300 times the equivalent amount of CO2. Yeah.
When I talk about it and I educate about it, and this is also from the literature. I mean, I'm a literature freak myself, so I read all the scientific papers. Well, the doctors and the people that now write articles are like, okay, 4 hours of intimate use of this pre-mixed. So you have the oxygen, you have the nitrous oxide. 4 hours of a mask on, mask off, mask on, mask off, because they will not inhale this for constantly 4 hours. 4 hours of intimate use is like now putting yourself in a gasoline car and drive 1,400 kilometers. So it really, really has an effect that staff members are good at catching the exhale gas. And why shouldn't they? This is also the safety for them. I'm pretty sure that the midwife you and your wife will meet will point out to you and your wife. You might even be the coach here assisting your wife that please exhale back to the mask. That will provide safety for me as a midwife, and I need to focus on both your wife and your baby. So please, exhale back into the face mask. And by that, we can capture it. Good for her. And we can lead it to not to the ventilation, because we actually now take the pipe going to the ventilation and turn that pipe in another direction and lead that to our technology. I mean, so all the gas that the staff can capture, either by a face mask or a mouthpiece, is going to be led into one of our units, either the mobile system or the central system. Both systems do exactly the same thing. They capture the exhale gas and they destroy it into nitrogen and oxygen, room air. What we do not capture is, of course, if you now come into the hospital with your wife and she's going to inhale gas from some kind of device and she exhale back. What if she now exhale back into the room? It's still a climate, concern that gas is, of course, now not captured. The midwives will try, or the staff members will try to correct your wife and say, please exhale back to the face mask. I need to protect myself. We know now from the literature that perhaps 20% is not going to be captured. We still have the 80% that we capture, and of the 80%, we destroy the 95%. The 20% that we do not capture, when I talk about it, I kind of address the situation of my wife driving a hybrid car. Of course, that will, be very climate friendly the first 50 kilometers, but then she will drive on gasoline. I can live with the 80%. I know that we will improve. I know that we will develop technologies, but I mean, the 80% of this climate gas being destroyed is a good thing. I compare money to patients. I also compare money to patients to climate. But if you now take...
That's the change we need to make, is to have the climate into not as the only parameter, but also being a parameter. And
I totally agree. But back to this competent team that was together on bringing this into Vidova. When I did talk with them, and they were all, very much focused on doing everything here right. Right for the patients, right for the staff members, right for the climate. When I talk about, okay, if we now do this right, everything right, what does it cost? I focus on taking the 200,000 euros and divide that out by patients. So I say, okay, if you now have the investment of 200,000 euros, what will that do for your entire CO2 footprint in your hospital? Because there will be a lot of good ideas that you can do, right? I mean, a lot of good ideas that you can bring in, a lot of good technologies you can bring in. My focus is on the nitrous oxide, where I say, hey, your CO2 emission, we can do something about, and there's actually a low-hanging fruit here. We know that the staff are already extremely good at capturing the exhale gas. We know that you have a pipe going to the ventilation. We redirect that down to central destruction system. What does that cost per patient? The best solution possible. What does it cost per patient? And if you take Vido, this hospital here in Copenhagen, as an example, well, 200,000 euros are your total investment. Then you have the best possible for everybody. It's 7,000 babies born per year. You know that 80% of those ladies will at some point raise their hand and say, where's the nitrous oxide? Let's say that it's like 6,000 babies born per year at that hospital with nitrous oxide then. Our system will last at least 10 years, meaning that in 10 years, the investment will have been used by 60,000 women. Now you take your investment of the 200,000 euros and you divide that investment with the numbers of patients that has used it. So you take your 200,000 euros, which might seem like a big investment, and you divide that by 60,000 women. I think you will come to a reasonable per patient cost.
It's a bit over €3 or something like that.
Exactly. So I think you will come to a reasonable cost if you now say, hey, best possible scenario for the women, best possible scenario for the staff, and best possible scenario for our climate. At that price per lady is a reasonable cost, I think. I think we will do. I think we will come into a situation where healthcare will be short-staffed, and we will need to find sustainable solutions on it, best possible solutions on it. And I know that I work with the greenhouse gas, and I know that we need to deal with that. But yeah, I do think that this program, when I talk about the nitrous oxide, I talk about it as being a program. Do I think that that will be implemented in more departments, in more hospitals? Absolutely, because the idea of using a pharmaceutical as a gas will also mean that you can fast track patients. I mean, your wife, when you will become a dad and your wife will give birth to a baby, why do they use it? Well, they use it because they can fast track the effect. So the effect wears off as soon as you kind of remove the mask. So it's very flexible and it's non-invasive. There's a lot of it does a lot of good things. So if you now go back to this hospital where we installed the central destruction unit, well, that hospital is now asking for mobile destruction units.
Interesting.
And that's exactly the same thing, that we have downscaled our technology to being a mobile thing. So why should these departments not? And this is what they will try to do. They know that some of the most competent and well-educated healthcare staff that they have are anesthetic doctors, anesthetic nurses, and they're short-staffed, meaning that some of the patients might not need that high of competence, meaning that they do not need general anesthetic. Is it possible now to relieve the healthcare system by removing some of those patients and take them, for instance, to another department where they have the program with nitrous oxide installed in a climate-friendly way on a mobile technology? Absolutely. And that is basically also what I'm extremely busy now doing, is that a lot of hospitals have the same problem globally, short-staffed. What do they do about it? They need to have now solutions where they can safely use, and I say it wrong because I don't really want to say less competent people, but people where they can accelerate the education faster. And that is, of course, this thing about inhaling a gas as nitrous oxide with oxygen.